item. No, sharp ngimele yena uthangeni. Yeah. Bese ngimenzile ke manje. Yeah. Yeah. Okay. It's COVID-19, pregnancy, and women's health. Pandemic. Discussing, yeah, pregnancy and women's health. Health. Yeah, women's health. EM''S. Yeah, she's trying to get hold of me now. I think okay. Hey, Doc. Oh, no. You can go in. You got the meeting ID, right? Oh, okay. Okay, let me give you the ID. Yeah, it's 278391 410. In my mind, I thought I sent you Anything ID, I'm sorry. Okay. It won't need password. It's fine. It says password. Okay. I'll send it to you just now. Okay, sure. Okay. Hey, Doc. Can you hear me?
Hi. Okay. Yes,
All right.
I can. I'm going to stop the video for a second.
Okay. That's fine. All right. So we have just about 5 minutes to go live.
Okay.
So it's gonna be an easy, it's more conversational stuff.
Yes.
So so the first five minutes or so, it's just about you.
Okay.
And then from there, obviously I'll ask about the global surgery, your current role, locally, globally, and all of that. And then we start, looking at issues around COVID-19, as far as issues of women's health, and pregnancy is concerned. Then you can just guide me there. You just take the discussion in whatever way, and then I will just link up.
Yes. Okay. Okay. No, I'm ready.
Okay, sure.
All right.
All right.
Cool.
Sure.
All right.
Good afternoon, ladies and gentlemen. My name is Dr. Fundi. Welcome to all of you joining us via various social media platforms, YouTube, Facebook, and also the Dr. Fundi platform. Today, we are going to be discussing issues around COVID-19 pandemic, but with specific reference to women's health and pregnancy issues. So we have a guest that has agreed to be part of this interview, a special guest, somebody I have great admiration for, Professor Salome Maswime. Now, this is an under 40 high achiever, all the way from Butlokwa in Limpopo province. She comes from a family that really respects education. She is a mother, she is a wife, mother to 2 boys. But with relevance to today, Professor Maswime is an associate professor and head of global surgery at the University of Cape Town. She is a qualified obstetrician and gynecologist who obtained her fellowship qualification from the College of Medicine in South Africa, and also a master's degree in ONG. She also holds a PhD in ONG, obstetrics and gynecologist. She is currently the president of the South African Clinician Society. She is a former research fellow, who spent some time at the Massachusetts General Hospital and Harvard Medical School. She is also a former lecturer at Wits University. Now, I am not done with her, with her CV. She has received a lot of awards to date. She was awarded the next, Einstein, a Trailblazer and Young Achiever by the president in 2017, President of South Africa. She was also amongst the 200 young South Africans by the Mail and Guardian on the same year, 2017. She was also Destiny Magazine Power of 40. She has also been awarded by the African Business Network and Africa Forbes. So she just has so many awards to her name. And I want to stress, she has not yet reached 40. So the question is, when life begins at 40, how much more are we going to get from her? So welcome to Dr. Fundi platform, Professor Maswime.
Thank you very much. I'm really excited to join your platform. Thank you.
All right. So, somebody from Butlokwa, outside Polokwane, what made you to decide, you know what, I want to be an obstetrician and gynecologist, and I want to be the best in that space?
Very interesting question. So, let me start off with my disclaimer. So my father was a professor at the University of Venda, later at UKZN. So I come from a family of academics. And so by the time I was born, my father was pursuing his studies. In fact, that's when he was finishing his master's, about to start his PhD. So I basically was born at a time, where my family, my parents were pursuing their studies and grew up in an academic environment. When my father was lecturing at the University of Venda, I was there attending graduations, really part of the academic scene. So that's how I developed a passion for academia, for education. But how I became an obstetrician, it was much later, after I decided to do medicine at the end of matric. and it was fine. It was a challenging degree. I wasn't quite sure whether I wanted to do this for the rest of my life. But when I got into, after internship, when I went into community service, it was at that point where, somehow I was put in a labor ward, and it became real when first it was the excitement, enjoying, delivering babies, mom is excited, you're excited, everyone's excited. But when someone dies, whether it's a baby or a mom, that really hit hard. And so that's how my passion developed for obstetric care.
Yeah. Okay. All right. So, but before you got in there, to train to become an ONG specialist, I also understand that there is an arty side of you. Can you just maybe tell us about that? And apparently you were quite good in some performing arts or something like that. So just tell us about that.
So I always had I don't know, is it the double life? Or I really enjoyed the arts world. In fact, if I had my choice, I would have gone into drama, performance studies. But, when I decided that that's what I wanted to do, it was too late. I was already in medical school. No one was going to let me leave medicine at that time. I tried, it didn't work, and I'm grateful that it didn't. But because I loved acting, writing plays, I would do things at church. We formed a creative arts team. We did productions on campus, our write productions, we did a lot of things. Even when I was working internship, comm service, I continued doing drama. So it's always been, my weekend life has always been music, drama, arts. And I started playing the trumpet in high school. So that was also a part of me that I continued to explore. When I was in varsity concurrently with medicine, as part of the KZN Youth Wind Band. And later, after specializing, I continued to play in my church band. So I've always balanced the creative and academic side.
Yes. All right. So how does that differentiate you to other, medics? The fact that you also have that art side of you.
So I think it's more the skills around, public performance, being able to, now I speak a lot about the work that I do and, educating communities, advocacy work, but I spent a lot of time on the stage doing other things that were not related to medicine. And I think that has prepared me, for the journey that I'm on. I did a lot of, organizing events. They were obviously around dramas and productions, but my work right now requires me to do a lot of those things. So I think it helps in how you engage with people, how you engage with an audience, and being used to that fast track. I have to get it right. I've got one chance to do it, to impress a crowd, for example. So I think it's the training. But it's also a safe space where, I'd find after being on call in Paraguay, I'd be exhausted, and going to pull my trumpet would also just be a relaxing, safe space, not having to think about anything that's going on in the world.
Oh, lovely. So do you still get any time, nowadays, because you have a very hectic schedule, do you still get time to play your instruments?
So I've got my trumpet here, but I haven't, I pick it up sometimes, but for the past year and a half, I haven't played formally or did anything formally. Since moving to Cape Town, I'm still, finding myself, finding my network. And so it's been a while, but I'm sure as soon as I find the right group, I'll probably start playing again.
Yeah. No, I think Cape Town is the best place, in terms of art. So I'm sure you will find a group. All right, let's get back to, the discussion today. Now, last year sometime, late last year, you actually came back after spending almost a year in Massachusetts, Boston, where you were also working with Harvard Medical School. How did that come about? What was all that?
Yeah, so I'd applied for a Discovery Foundation award. It's their most prestigious award. They give it to one person in the year, one person a year, every year. And so in 2018, I was the person that they gave the award to. It's an award worth 2.1 million. It covers literally your expenses to live overseas with your family or whoever you want to go with. So, and also as part of the costs of being there that go to the hospital and to the institution. So I took a chance and applied, just like anyone else. And I was lucky to be the one that got that opportunity.
So what did it mean to you winning that, that fellowship?
So it was absolutely exciting, you plan your career and it was just one of those, game changers, You get the opportunity to go to, one of the best universities, one of the best hospitals in the world. You get to meet amazing people and learn new things. And I was at a point in my career where I wanted to do, the question was, what's the next big thing? And I wanted to learn new things, what's cutting edge, how to become a cutting edge scientist, researcher. And so I moved into a place where I was mentored by people who have advanced, so much in their careers, and they were able to teach me a lot and share skills with me. So there was a lot of growing development, new networks, new space, and I think it opened up new doors for me. Yeah.
All right. So that stint at Harvard and Massachusetts Hospital, how did it prepare you for your new role? Because now you moved, when you left, you were still at WITS. And then when you came back, you didn't go back to WITS. You now went and joined a UCT as the head of global surgery. So how did that stint help you in your current job responsibility?
Yeah, so when I left, they give you a choice of which department you want to work in, what is it that you want to learn. And so I had said from the beginning that I was interested in global health. And so I was placed in the Center for Global Health. And so that was really a year to learn about global health because, in South Africa, there aren't institutions that are, except, there's only one institution I know that is formally teaching global health. But whilst I was there, because I was now learning about global health and my work up to that time, my research had been about cesarean sections. I was advised to start visiting the Harvard Global Surgery meetings. And so I started visiting them. They invited me to give a talk there, and I interacted with them quite a lot. So by the time I was coming back to UCT, I was coming back to South Africa, I'd been part of this global surgery network and with this experience in global health. And so it made sense to move, that the next thing was really to get into global international work.
All right. But just for people like me who don't know much about global surgery, can you just unpack it in a few words? What is this global surgery that you are heading at UCT?
Yeah, so I'll start off, I'll make it very simple, so that it's easy to understand. And so, we've all at some point in time been sick, and, often you get sick, you go to the doctor, there are two options. One, we're gonna give you medication, or two, you need to have surgery, you need to have an operation. And we've all seen and heard about people that have died during operations where things did not go well. And I think the part that many people don't know is that, if you look at, low and middle income countries, places like Africa, their continent, and other countries with similar economies, there's about 5 billion people that don't have access to safe surgery. And even when they do, there's a large proportion of people that die from surgical complications. So my job is really about looking at ways to improve surgical outcomes across populations. Our focus is the African continent, but we work together with other institutions, other universities in the world, other big institutions like the World Bank, United Nations. We partner with them to see how we can improve surgical outcomes in South Africa and on our continent.
Right. So just listening to you, so it's not just about surgery that is done within the ONG, field, because it's across the different surgical disciplines.
Yes, so I actually work with, the obstetrics and gynecology department, the Department of Surgery, which has about 13 surgical divisions, which include, ENT, colorectal surgery, basically any surgical discipline. I work with the anesthetists as well, and I also work with the School of Public Health. And so those are the 4 main departments that I work with, bringing together surgeons, clinicians, and also bringing together the public health people looking at health systems. We also work with the rehabilitation, so the occupational therapists, the physiotherapists. So it's a wide network.
Yeah. So you said there's only one institution in South Africa that actually has got, global surgery. Now, are there any efforts
not anymore. So UCT has global surgery. Stellenbosch has got global surgery. Wits also has got global surgery. In the different institutions, the names are different, but essentially there are 3 institutions that are really that started global surgery last year.
So why don't you help your alma mater to also have one, UKZN?
UKZN, I'd love to. I'm sure I've spoken to the dean, Prof. Shoba, and said we need to, something needs to be done there. I think the more global surgery units we have, the better.
All right. Now, what about the African continent? Because my understanding is that your focus is not just about South Africa. You are actually looking at how to ensure, access to safe, surgical interventions across the continent. We in this continent have got some of the worst outcomes when it comes to things like maternal mortality and all of that. So, can you just give us a sense about how large is the challenge within the African continent?
Yeah, so it's twofold, because on one hand, especially what COVID-19 has shown the rest of us is applies a lot to global surgery. I mean, one of the areas that is within the global surgery discipline is critical care. And, these are things that we've been looking at for a while, but you start realizing, for example, the disparities between the number of ventilators that are available in South Africa versus in other African countries, and what needs to be done. So there are a lot of problems, but there also is a network of people that are doing what I'm doing, and we try to work together. We're constantly trying to expand the network so that it's not just a South African thing. But even with South Africa, we understand the disparities between private and public healthcare, and also across different areas, rural areas versus the cities. So we are aware that we try to work on some of the national issues, as well as trying to partner with other institutions across the continent.
So you basically are trying to expand and address, the issues, challenges relating to the outcomes of surgical interventions across the continent. All right, let's now get to South Africa and talk about COVID-19. we are now at a point where we've just, I mean, our first case as a country was on the 5th of March. Now, today, in terms of what I've just seen, we have 24 deaths relating to COVID and 2,003 confirmed cases. So that number is going up, but not as fast as it was, you know, in the period before lockdown. But from your discipline now, which is, you know, O&G, how has COVID-19 pandemic affected, you know, both from a service provider point of view, that is as the professionals, but also the people who require the services, you know, of O&G specialists?
Yeah. So, you know, the first thing I want to say is highlighting how, you know, pregnant women are a vulnerable population, and for many reasons. And so the challenges that pregnant women face with COVID-19 are quite unique, are quite special, and need more attention. Whilst, you know, the field is evolving every day, the information.
Yeah, Doc, I want us to carry our viewers nicely. Why do you say pregnant women are vulnerable?
So pregnancy is not a natural state. You know, when you're pregnant, you've got a lot of physiological changes. Some people fall pregnant already with certain diseases. You know, you might have had hypertension, diabetes, you know, there are many things. And also pregnancy itself, every pregnancy is unique and comes with challenges. Some women have got complications. So, you know, when it comes to COVID-19, pregnancy is viewed as a high-risk state, because even though a woman has got her own risks within pregnancy, but COVID-19 also poses risks towards the woman as well, special risks that I obviously would want to go into a bit in a bit more detail.
Yeah. Okay. So, in terms of international experience to date, since you know, this pandemic came up since end of last year, end of December. So there's been enough data that actually shows that women who are pregnant are a vulnerable group as far as COVID-19 you know, infections are concerned. So has there been, you know, deaths or severe, severe cases of COVID as a result of the state of pregnancy?
Okay, so what I want us to have it, you know, just to clarify, you know, pregnant women are a high risk group, but COVID-19, but it doesn't mean that COVID-19, you know, that pregnant women are more susceptible to COVID-19. That much we know. Yeah. That much we know with the evidence that the risk that a pregnant woman has towards COVID-19 is very similar to the risk of a woman that doesn't have, you know, that is not pregnant. However, pregnancy is special because, you know, you're thinking about two people. There's an unborn baby as well, who's also vulnerable to having other risks and complications. So I want to break it down in this way that, you know, do pregnant women with COVID-19 have higher risks of miscarriage? You know, there isn't enough evidence suggesting that. Is there a risk of pregnant women having more abnormalities, babies, or transmission to the baby at birth? There isn't enough evidence suggesting that. However, you know, there is a bit of data saying that pregnant women might be at risk of having preterm labor. But even in the cases that have been studied, it is not clear whether it was because of the immune response to the disease or whether it was because of the COVID-19 itself. So as the disease is evolving, we're all learning new things about it every day. But what we need to appreciate is that, you know, that pregnant women are a special population and will require more attention. And when I'm talking about attention, I'm talking about things like continuing with antenatal care during pregnancy, for example, whilst, you know, we can't stop pregnancy care just because of the situation right now, because it poses more risks to the pregnant mother and to the unborn baby.
Yes. Also, basically what you are saying is those people who are pregnant, who have been attending their antenatal clinics, public or private, they must continue to do that, because the overall purpose is obviously that you have a healthy pregnancy, hoping for a healthy outcome, that is a healthy baby. So the fact that there is COVID-19, there is a lockdown, is no reason for people to stop their antenatal clinics.
Yes, pregnant women should continue attending antenatal clinic. They should continue taking whatever treatment or medication they've been on. That's the international standard. Those are the international guidelines right now.
Yes. Now, I understand that you are part of some international study around COVID-19 and pregnancy. Can you just talk about that and what insights, or what is it that you guys are looking to achieve, in terms of that study?
Okay, so I've been part of a group called the International Network of the International Obstetric Surveillance Systems Network. And so right now an international study has been started. Some countries have started it. We have only, we're in the process of getting all the regulations, approvals for South Africa. But we're planning, we'll be starting, in the next few days, weeks, the South African obstetric pregnancy COVID-19 study. And in this study, we're looking to describe, describe the outcomes of women who are pregnant who with COVID-19. Because understanding this is going to help us understand the disease more, and it's also going to help us understand, what is different from African women, from South African women who have COVID-19 and diseases that are more unique to our population, along with the COVID-19. So it's a study, part of an international study, to understand what happens to the South African woman who has COVID-19.
All right. So I think for those people who were concerned about with contracting COVID-19 during pregnancy may actually cause maybe abnormalities and stuff, you've cleared that up. You've just said there's a higher chance, they have a slightly higher chance of premature babies, basically, right? Or preterm labor, right? That's what you've just said. All right, but how else are people who are pregnant affected by this? And I'm not just talking from a clinical point, I'm talking broadly.
Yeah, I think the other important issue is mental health, maternal mental health. Pregnancy is also a time of a lot of anxiety. A lot of women, depending on what's happening with your pregnancy, there's just a lot of anxiety around what's going to happen, what outcome, will the baby be fine, especially if you've got other conditions at the same time. So in this time of lockdown, and the pandemic, many of us are stressed even without pregnancy. So we understand that there'll be more anxiety. And so it's important that even as healthcare workers, that we ask the right questions, we give the right information, and that we're available at all times to help those who are pregnant.
Okay. All right. So, because just about a week ago, I hosted a psychologist here, a clinical psychologist, I wanted to understand what kind of emotional health challenges or even mental illnesses that could be precipitated by being cooped up in one's home. So now you have got stresses relating to the pregnancy itself, plus those that everybody else is having, from being limited to staying at home. So basically, it even increases the risk that you had talked about, that they are a vulnerable group. Now, I also understand that one of your research interests is around HIV, HIV. Can you just talk about that in relation to COVID-19?
Yes. So, one of the challenges will be answering the question about pregnancy plus HIV plus COVID-19. And at this point, I don't think anyone really has the answers. But the research that I've done on HIV, and one of the areas I work on is looking at stillbirths and looking at outcomes of women who are HIV positive. And what we've learned from that work is, the importance of, I think what has been important, we have been seeing that, as the national regimen changed in South Africa, pregnancy outcomes improved as well. Maternal mortality rates went down. We've been able to see that quite clearly. And so COVID-19 being an infection itself, I think there are lessons about, adherence, getting attention quickly if you think you're sick, if you've got symptoms, being identified early, being treated properly. So I think there's a lot of lessons as South Africans that we've learned from HIV and from managing HIV positive women who are pregnant. And I think some of these lessons we can also apply to COVID-19. But the question about, does COVID-19 make HIV worse, or does HIV make COVID-19 worse? None of us can answer that question, especially relating to pregnancy.
Okay, all right. Now, one of the challenges we have in South Africa, is the issue of young mothers, as in like teenage pregnancies, under 19s. We've even seen people who are under 13 who are actually, pregnant. So, what are the issues there? Being pregnant at that age, and maybe you get COVID-19 on top of that. Is there any higher risk of, adverse outcomes or something like that? I know it's still early days, but I'm just throwing it there.
Yes. Yeah. So teenage pregnancies, it's a very special, issue. I worked part of a clinic where I worked in a maternal mental health clinic, and one of the special populations that we used to see were teenagers. And contrary to what many of us tend to think, there's a lot of them come from backgrounds of abuse and a lot of things that are not going right at home, but you only find out when you speak to them and when you inquire and when you ask deep questions. And so some of the things that we used to do was to have the psychologist and the psychiatrist see them and intervene, and sometimes even helping the mother cope with the grandmother, basically with their daughter's teenage pregnancy, would have those systems in place. So this also raises up issues on gender-based violence increasing during lockdown. And those are so those are some of the realities, those are some of the real things that are happening. And I think when we start partnering with NGOs, with organizations that are actively helping with such to solve such problems and to provide support, I think that's the only real way around it. It would be difficult to answer, teenage pregnancy with COVID-19. We're all learning. We are all learning here. We are all going to see. And I think the same principles apply, that we need to try and prevent. We need to self-isolate, we need to prevent social distancing. All those principles continue to apply to everyone. And we want to prevent transmission of the infection. And once you've got the infection, we want to treat, you know, our patients and we want them to heal. You know, we don't want anyone to die from COVID-19 at this point, especially if they are pregnant, especially if they're a teenager as well. And the other thing that I also wanted to mention was the issue of breastfeeding. That, you know, the question has come up quite a lot. Can I breastfeed if I've got COVID-19? Yes, you can. You know, the current regulations do not stop women from breastfeeding. It's important. It's important. And if a woman has decided that this is how she's going to this is what she's opted for, then we need to encourage that. But there are some basic protective, like wearing a mask and all of that. But some things have to be individualized according to the severity of the illness. And so speaking to your doctor and asking simple questions is important once you're in that stage.
Yeah. Now, just another issue. It may not be COVID-19 related, but I'm just throwing it there. I'm taking the opportunity that you are in front of me, and I must ask these questions. Now, South Africa, especially the private sector, a lot of people are accusing, you know, that there is a very high Caesar rate. That is, people who give birth through cesarean section, which is out of line to what is happening elsewhere in the world. Now, I just want your thoughts there, you know, or your insights. What could be driving this? Because in the public sector, it's not as bad, you know. However, in the private sector, it's very, very high.
So, okay, so you've touched directly on the work that I do on my research area, because cesarean sections, you know, that's the work that I'm quite passionate about. So, you know, if we look at it across the continent and not just in South Africa, you've got two things happening at the same time. South Africa is unique, it's different, but you know, you've got a world which has got a very high cesarean section rate, especially private sector, and cesarean sections that are being done that are not necessary. But at the same time, you've got areas that women who need cesarean sections are not getting them, where women will die before they can have a cesarean section. The one that is over-reported is the one on cesarean sections that are so high and it's being abused basically. But the number of women that are dying in African countries just because they couldn't get a life-saving cesarean section, that is not spoken about, you know. So we've got that parallel issue going on at the same time. My work, I'm more passionate about the women who need cesarean section, but I think, you know, when we start educating women as well, educating communities to say, you know, let's not have cesarean sections if we don't need them, you know, the dangers of a cesarean section, that a cesarean section almost doubles your risk of complications. The healing takes longer and all of that. Some of these things are about how we educate, how we talk amongst ourselves, and how we educate our communities. And so, you know, if you've got a community where it's been, you know, I'll make an example. When I work in the public hospitals, and I say to my patients, would you want to have a cesarean section? Most of the patients will say no. And when you inquire why, they come from places where people die, you know, at Caesar. They had such bad experiences that they don't risk my life by giving me a cesarean section. And so you've got that a community which thinks completely different about it, and then you've got another community which says, you know, I'd rather have a cesarean section, I'd rather die than have a cesarean. You know, we've got two different stories. So yes, South Africa has a high cesarean section rate. The private sector has a very high cesarean section rate, and I think we cannot continue to justify cesarean sections that are not necessary. But let's not forget about the women that die waiting for it to happen.
Yes. All right. But still on that, I know, the issue of, you know, patients are much more assertive nowadays, you know, to a point of saying, doc, I want my baby to be delivered on this date. It can be a planned thing that will ensure that the anesthetist is available, the pediatrician is available, and all of that. I want an ideal situation for my, and I think as a private doctor, it must be difficult to say no to something like that, but also there's the whole issue of litigation as well, where now increasingly law firms are focusing on medical litigation as a result of the tightening of screws with the road accident fund. So those things could also be, to some extent, driving this.
Yes. So, I mean, on the first issue, how we are socialized is very important. Somebody has spread the word that, you know what, you can have a Christmas baby if you want to, you can choose. It doesn't come from nowhere, it's a socialization, and when we start changing the socialization, when we start advocating for natural births, it's going to take a long time. It's not going to happen overnight. But when we start I've seen it in other communities internationally, where there are places where, where rich, educated women are not saying, in fact, what do they say? I'm too cool to push, that's a socialization that we need to get rid of and really make informed decisions. So health literacy, advocacy, that's very important. Policies in the public sector, it's very, very strict. You can only choose to have a Caesar under certain conditions. You've had one, previous cesarean section, then let's discuss it and let's decide together. But you can't walk in and say, so policy comes into play. But on the issue of litigation, that's a very serious, that's a very serious issue, especially within the obstetrics community, and I wouldn't do any justice going into it, because
I was trying my luck. I was just trying my luck to see if, when you talk to your colleagues in private, because my understanding is that, the premiums that they have to pay on an annual basis are quite high, to a point where, and obviously they become worse if there are claims against them. So I was just throwing it in as a possible driver, that safety first type of approach.
From a public health perspective, the number of people training to be obstetricians have reduced because of this issue. And so we're running into trouble because fewer and fewer people are wanting to be obstetricians, and the quality of care, the quality of medicine that we're practicing is also threatened by making medical legal acting out of fear versus acting out of making sound decisions.
So now, what other issues would you like to share with our viewers relating to COVID-19 and women's health? I mean, we haven't talked about things like contraception, for example. In South Africa at this moment, there is a shortage of contraceptives, a serious shortage. The injectables like Nysterate are not available, and some of the oral contraceptives are also not available. So this is before COVID, and then there is the issue of COVID, and people may not be able to go and have their stuff because it may not be seen to be essential. So do you think going to get contraceptives at health facilities should be considered as essential service?
Yeah, so, family planning is, family planning clinics are supposed to be open. Those services are considered as essential services, because what you don't want is the risk of increasing the rate of unwanted pregnancies after this. Unwanted pregnancies, there are just too many consequences. One of the consequences is obviously increasing the maternal mortality, and all sorts of things. So women should be empowered, and women should continue to receive their contraception contraception at this time. You know, but obviously we understand that it's, you know, there are fears, there are questions, you know, can you walk out of your house just because you need contraception? There are stigmas, there are all sorts of things going on. But I think it's our responsibility to make sure that everyone is empowered, because, you know, we don't want to end up with worse maternal outcomes after, or reproductive health care outcomes after COVID-19. You know, I think the country has done so much to reduce mortality rates, to try and meet the need for contraceptives. So we don't want to work so hard at preventing COVID-19 that we end up with high skyrocketing maternal mortality rates and unwanted pregnancies and unplanned pregnancies.
Yeah. So okay. So what other issues do you think would be of interest for you to share around, you know, and these are not necessarily clinical issues, but I'm just talking broadly, you know, issues around COVID-19 that I might not have touched on?
Yeah, I think that the other issue is, you know, women that are at risk of having cervical cancer. If you've had abnormal pap smears, you know, some of the services are still available for that. We don't want, you know, women to die of gynecological cancers post or during COVID-19. Same issue with breast cancers, that, you know, we want women to still continue receiving the treatments that they're supposed to get the management, the medication, everything that they should get. So I think it's important that if you know that you're at risk of something, or, you know, you need medical attention, to seek the medical help in this time.
All right. So one of the things I read in your profile was that you are an advocate for women's health rights and issues of equity in healthcare. Can you just talk about that, especially the last part about women's health rights and equity in healthcare? Can you just, what's your involvement there?
So, okay, so, you know, a lot of, I've always used my research to do advocacy. And so I study certain things so that I can have a voice on things that need attention. Maternal mortality and perinatal mortality are two things that I really, that's my key area of advocacy. And I think the one message that I've constantly tried to bring across is that women should not die from conditions that don't kill them in other parts of the world. And
just sorry to interject. Let's just unpack, because we've been using this maternal mortality and peri whatever. So just for somebody who did not go to medical school, just what are we talking about? Maternal mortality and perinatal mortality.
Okay, so we're talking about maternal deaths when women die from pregnancy-related complications. We're talking about stillbirths. We're talking about babies that die within the first few days after birth, and how the world has done a lot of work to eradicate pregnancy-related deaths, but South Africa's pregnancy-related deaths is still 10 times higher than the deaths in high-income countries. You know, those are the kind of facts that show us that women are still dying from conditions that they don't die from in other parts of the world. And that has to do with health systems, leadership, how we organize our health system.
Yeah, access to quality.
Yes, yeah. So my work my advocacy is in working towards us having high quality care for all women, regardless of race, gender, where they live, you know, what part of the country they come from.
All right. Now, we are about to get into our winter season. And obviously flu is a big issue. Now, what advice would you have to pregnant mothers at this time of COVID-19 in relation to flu vaccination?
So the vaccine has been found to be safe for pregnant women as well, and it's been recommended that, you know, that it be used as well. So that's the advice that I would go from, that I would give, and especially.
So you're basically saying, pregnant moms, go get your flu jab before the winter season starts. It's safe enough. It won't harm you. It won't harm your baby. That's.
Well, yes, but right now, you know, we don't have to wait for winter.
Yes.
COVID-19 is upon us, so
yes.
I don't think we have to wait for winter.
Yes. Yeah, no, because normally people start taking their flu jabs from around the end of March, during the whole of April, because then from around mid-May, we start seeing a lot of these cases. So basically, whilst we're on lockdown, but people can still be able to go, and it's an essential service. They can go to their pharmacies or to their treating doctors to do this.
Okay, so I would not put it in that way. I would say that you,
please say it in your way.
Along with your antenatal visits, along with, you know, the visits that you're supposed to have to the hospital, in any case, that is when you should time it. I wouldn't say that leave your house and go right now for that, but plan it along with your medical visits. Yeah.
All right. Okay. Now then, I'm happy with that. Yeah.
Individualizing as well, that, you know, you always discuss with your gynae, discuss with your team, so that everything is tailor-made for the patient that is there.
Okay, but you think there could be benefits of having it?
Yes.
Okay. All right. So, Doc, as we are trying to wrap up, what overall advice would you give to pregnant moms who are anxious? They are locked up, like all of us, in the homes. There is the normal anxiety that you spoke about pregnancy in general, and there's added anxiety about this COVID-19. What words of encouragement, do you have for them, or tips?
Yeah, I mean, and not just to the pregnant moms. I think many of us are wanting to stay positive in this time, or wanting to, you know, we're hoping that things are gonna get better. You know, the curve is flattening, and we want to hope for the best and not be afraid at this time. I think we've seen the great leadership, we've seen the efforts, all the hard work. And so being assured that there are people that are working very hard to try and improve things, to try to flatten the curve. But if you are pregnant and you're going through this time, you know, it's also a time to reflect on you know, I want to say not everyone is excited about their pregnancies. That's the experience that we've had. But pregnancy is also a very joyous time for families, for many families who are anxiously, excitedly waiting for the newborn, for the new baby that's coming. And sometimes you really have to think positively and think and rather look at the positive things that are gonna come out of this, what you're looking forward to, rather than being in the anxiety, because stress itself plays a role in having adverse pregnancy outcomes. And so trying to find, you know, having positive thoughts and working on your own mental health. But again, if you find that you are not coping with you can see that the thoughts that I'm having are not normal, this is excessive, you know, seeking help early enough and saying, you know, I think this is a bit too much. An example will be like a woman who's had a baby and she starts feeling, you know, uncomfortable, unhappy. At some point you realize that, okay, no, this is not just normal, postnatal blues. I think I need a bit of help here. And that's when we say reach out for help. There are people that have been trained to look after these issues. So reach out to us to help you if necessary.
Yeah. All right. So you mentioned quite a number of times that in South Africa, we've made a lot of progress in terms of reducing deaths during pregnancy, maternal mortality. But in the continent, we still have a huge challenge. What is being done around that, especially in the under-resourced communities, in your engagements, across the continent?
Yes, I mean, there've been a lot of activities supported by the international communities trying to assist many countries to improve maternal outcomes. Some of the interventions, like I said, are also governed by policy and by health systems and having access to care. Whilst we spoke about a cesarean section rate in South Africa that is so high, but countries with a cesarean section rate of 2%, some of our neighboring countries, those are the countries that have to improve access to care, access to, access to cesarean sections. And so, again, each country will have a different challenge that they need to solve. But there have been things like in South Africa when changing antiretroviral regimens, improved or reduced the number of maternal deaths nationwide. So there is enough proof that, policy can really improve outcomes.
All right. So, Doc, we are done with our presentation. However, our interview, not a presentation. Right now, you are still to hit 40, right? I keep on mentioning this because you've achieved so much. What's the next thing for you? I mean, when you are 45, what do you think, or what would you wish to have achieved? What drives you, What's the next thing that you feel, if I can achieve this by age 45, then I will know that, I'm on the right track?
Yeah, so, it's always a difficult question to answer because, one wants to see the impact of the work that they're doing. It's okay to have titles and all of these, that's fine, that's nice to get promotions, but if you're not seeing an impact of what you're doing, the world is not changing, then or something, your community isn't changing, then there's still a lot more work to be done. And the story that I started with at the beginning, ComServe doctor, suddenly faced with, 2 maternal deaths in 1 week. I knew at that point that, okay, I needed to specialize. I needed to get the knowledge right. But it only exposed me to more maternal deaths. And after even becoming a specialist, moving into the PhD, it unfolded an entire world on health systems and how that can be used to improve outcomes. So I was worried about 2 deaths in rural KZN, only to find, there are 800 women dying every day from pregnancy-related complications across the world. So much more than I want certain positions or titles, it's wanting to get to a point where,
impact.
I've done something that would, yes, an intervention that will change outcomes, especially for African women.
Yeah. So have you figured out what your life purpose is, Doc? Why are you here on Earth?
Well, it's the what I'm doing every day, trying to make a difference and trying to use the skill sets, the gifts that I have to make a meaningful contribution. And also, it's not just about my work, it's also about the people that I work with every day, the medical students, you know, the people that I'm able to impact, to inspire, to mentor. You know, mentoring is a big part of what I love doing, and that keeps me waking up every day to do what I do.
So is Daddy happy that you know, his little girl is now really making some serious impact in the continent and in South Africa?
Yes, yes, he is. Yes, he is. I think I'm the youngest in my family, and you know how it is. You put a smile on your father's face, you know, it keeps you going. So it's been such a validation, receiving, you know, I don't know, affirmation from my family. Yes.
Yes. And I think the last one from me is to your better half, Gundo. You know, I think he's a model husband, you know, and may he continue to support you in your endeavors in the way that he has been, because then that way it actually allows you to flourish. On that note, we will end our discussion, Doc, and the video of this interview will be available within the next 15 minutes. So that you can then circulate it amongst, you know, the people who might have missed it. I think it's important that people get inspired by people like you, but the key reason for you to be here was for us to touch on some of the questions that some of my you know, connections had around COVID-19 and pregnancy. So thank you for your time. And we look forward to talking to you again one day on something else that you are doing in relation to global health. Oh, sorry, global surgery.
Thank you very much. Thank you.
All right. Thank you there, Doc. Goodbye.
All right. Bye.